Hello, let's talk about peptic ulcer disease. Within this SDL is also a discussion on gastropathy, which is similar in presentation to gastritis. So test questions will focus on making it clinically obvious that a patient has a stomach problem through giving you symptoms such as dyspepsia or perhaps vomiting or even bloody stool or anemia, because bleeding, GI bleeding, is a complication of gastritis, gastropathy, peptic ulcer disease, and even some stomach cancers. And so that's how they're going to introduce to you, oh, this patient has a disease of the stomach. And then from there, it's going to get into the histology of the matter, because that's really how you have to make this diagnosis when a patient does have inflammation of the stomach, is through a tissue section obtained on biopsy. And that will tell you whether you have a gastritis or a gastropathy or an ulcer or a cancer or a polyp, etc., going on inside the lining of the stomach. So that's our background. We begin this SDL by talking about some definitions. Gastritis is inflammation of the mucosa. Gastropathy is same thing, same locality, gastric mucosa, but you just don't see neutrophils and you don't see lymphocytes. So upset stomach basically for both of them. And the presence of immune cells on biopsy is what separates the two. Gastritis is most commonly due to Helicobacter pylori, and you can also have an autoimmune gastritis. Gastropathy is typically caused by chemical irritants. Chemical gastropathy is the most common subtype of it, also called a reactive gastropathy. And non-steroidals, things like Advil, aspirin, acetylsalicylic acid, anything that blocks the formation of prostaglandins by cyclooxygenase will, as we'll see, serve to damage the mucosal lining of the stomach, because the mucous lining of the stomach is dependent upon prostaglandins, specifically PGE2 and PGI2, for its production and maintenance by epithelial cells. Gastritis is recognized as acute and chronic. Acute gastritis is most often subclinical. The patient will just say, oh, my stomach is upset, but I don't need to go to the doctor, because you don't go to the doctor for every little rip stitch, right? When neutrophils are present in the gastric mucosa, we're calling it an acute gastritis. But when those immune cells, when we transition into the adaptive immune response, which is like your memory response and your cell-mediated response involving B cells and T cells, that's when we're going to call it a chronic gastritis. And so you gotta get pretty close in terms of a magnification in order to make that call between neutrophils and lymphocytes. But even pretty far zoomed out at a low power magnification, you're going to be able to say, oh, this is a gastritis versus, oh, this is a gastropathy, because in a gastropathy, as we'll see, you will not see any immune cells at all. We make the diagnosis by biopsy again, and laboratory studies really do aid our differential. Once we figure out, is this a gastritis or a gastropathy, then we're going to call in our blood work and try to get down to a root cause of whatever. So where we'll start is by ruling in or out Helicobacter infection, and our most common test for that is the urease breath test, in which we will administer oral radio-labeled urea. And if the patient has Helicobacter, well, that bacteria has a urease enzyme that can break down that urea into 2 ammonias and 1 carbon dioxide. And so the patient will then breathe the carbon dioxide. It'll diffuse up and out from the stomach, and we'll be able to detect that radio-labeled carbon dioxide. And that's what's going to be a positive urease test. We can also look at pepsinogen in the blood, because patients with a Helicobacter infection are going to have a elevated plasma concentration of pepsinogen 1, and that's due to chief cell hypertrophy. or hyperplasia, I should say. And then the reason why we look at serum pepsinogen is to make the differential between Helicobacter gastritis and autoimmune gastritis. And in an autoimmune gastritis, there you're having a CD4-based attack on parietal cells. And so chief cells will get caught up in that damage too. And so you'll eventually start making less and less and less pepsinogen in an autoimmune gastritis. And that's why you would see a decreased serum pepsinogen too in that cause of gastritis. And it's also important to note that when we're referring to our gastritis, Helicobacter and autoimmune, you can tell them apart most obviously by where in the stomach is affected. And Helicobacter pylori, it's got pylorus in its name. It's going to affect the pylorus and the antrum. But autoimmune gastritis affects the body of the stomach. And that's because it's an autoimmunity against parietal cells, and parietal cells are found by far most prevalently in the body of the stomach, and not nearly as much in the antrum, and certainly not in the pylorus of the stomach. So that's the basis for different pepsinogen concentrations in those two different gastritis. We do have a page or so on acute gastritis in this SDL. I don't think it's anything that we haven't covered in the previous SDL. Again, gastritis, neutrophils are in the lamina propria. Gastropathy, you don't see neutrophils. Now, remember that the lamina propria is a sublayer of the mucosal layer of GI epithelium, or not really epithelium, but the entire GI tract. In your gastrointestinal tract, you have an innermost mucosa adjacent to the lumen of the tract. Then you have a submucosal layer, which is mostly collagenous connective tissue. And then you have a muscularis layer. And the muscularis layer of the GI tract has two layers, really. It's got an inner circular layer of smooth muscle, and then an outer longitudinal layer. And then nested or invested within the muscularis externa is one plexus of nerves. And then on the inside of the circular layer of smooth muscle is another plexus of nerves. So that's the gross anatomy of it all. Now, the lamina propria is where you see neutrophil infiltration in the setting of an acute gastritis. And here's a good example. And you specifically see neutrophils in the neck region of gastric glands. And when we talk about the neck region of glands, we're basically talking about, well, kind of like where your neck is on your body. You know, it's on the upper half of your body. It's not down at your feet. And so glands are like that too. Their neck region is kind of the topmost, so to say, whenever you're considering the lumen to be up and the floor or the base of that tissue to be down, the neck's up at the top. And so you're going to see neutrophils in the neck zone in an acute gastritis, and that's exactly what we're observing on the tissue pictured on this slide. Notice how many neutrophils that we're seeing above the dotted line that I've drawn in green. And there's lots of redness up in there too, representing just some small hemorrhaging. And below that green dotted line, you just see pretty normal glands, and you don't see very many neutrophils at all down there. So that's what tells you you have a gastritis on your hands. And you can compare that to the normal stomach, and you'll look above the dotted line there and you won't see any neutrophils. And so understand the normal histology of the stomach so that you can be able to recognize whenever it is abnormal. Helicobacter does give you gastritis. Cytomegalovirus may give you gastritis. You can get Candida albicans in the stomach. You can get histoplasmosis that affects the stomach. Some parasites may burrow into the stomach wall. Primarily, the Anisaccidae family of roundworms might give you anisaccidosis. And that's following ingestion of raw fish. And the nematodes have a tropism. That means they like to go to that one tissue. They have a tropism for the stomach. So how is that parasitic infection going to present? As epigastric pain, big stomach ache and throwing up a few hours following the meal. You can also get an eosinophilic gastritis, just like you could get an eosinophilic esophagitis, right? And that's going to be in patients who typically have a positive past history for atopy, which is a specific allergy. And you're going to see lots of eosinophils on biopsy, and those are very red, and you should not miss those. So Helicobacter is the most common gastritis. You think you're going to get some Helicobacter questions on this exam? I think so. It's all over the place in this SDL. Last one too. It typically doesn't give you that bad of a gastritis. Again, it's like a few Helicobacters. No big deal. Your stomach can make more stomach acids to buffer the fact that helico makes a lot of ammonia. And so it does that, and you maintain normal function for a long time. And typically patients with a Helicobacter infection will present in the chronic stages of their gastritis, maybe even present with some of the complications of gastritis, such as we've said, hemorrhaging or hematemesis, vomiting. Maybe it's an obstructive lesion. It gets so big, or maybe it ulcerates and then it segues into peptic ulcer disease. So gastritis is typically not the presentation. It'll be a complication. And again, Helicobacter likes the neck, the mucous neck region of the gastric glands, and that's what we've emphasized in those slides that we looked at earlier. That's the neck region right there. And what are we seeing in here? A lot of inflammatory cells, all of these neutrophils in here. Those dense cells with not a lot of cytoplasm. Those are lymphocytes, neutrophils, immune cells. And one more look at normal in comparison. All of these cells that are kind of hollowed out or washed out up here, those are called foveolar cells. And what that means is basically epithelial cells, and they're specialized to secrete mucus to protect the stomach. So that's all we'll talk about gastritis. Again, you're going to know that the patient has a stomach problem. They will literally say, "Doc, my stomach hurts." Like, not a lot of thinking involved there. The thinking is involved in the differential. Gastropathy. When inflammatory cells are rare or absent, the term gastropathy is applied. Gastropathy is usually caused by gastric irritants or by mucosal ischemia or vascular congestion and stress-induced injury. So if you've ever heard the term stress ulcer, you can get one of those in your stomach, and it can lead to an ulceration or even a bleed, a little micro hemorrhage, and that could lead to acute blood in the stool, right? And that could be how you diagnose a stress ulcer, either that or endoscopically. All forms of gastropathies break down the mucosal barrier, permitting acid-induced injury. So there are no neutrophils there because in our traditional inflammatory response, the very first step in an inflammatory response is the recognition of a pathogen-associated molecular pattern or a damage-associated molecular pattern. And that's why I believe there are no neutrophils in a gastropathy, is because, well, there's no pathogens involved. So there's no PAMPs to activate cytokines, which will attract neutrophils. And there's really no damage-associated molecular patterns involved either. And the reason I believe this is so is because the stomach is so acidic that whenever the mucosal barrier dissolves, the acid of the stomach just melts cells, and the low pH of the stomach just denatures proteins. It denatures damps before they get the chance to bind and activate an inflammatory cascade. So I believe that due to the mucosal destroying nature of gastropathy, that's why you don't see neutrophils. You don't have the damp signaling. You don't have the TLR activation, so you don't get the cytokines, so you don't get the extravasation of neutrophils into that tissue. NSAIDs are the most common agents of gastropathy associated with acute hemorrhagic erosive gastropathy. So that's 4 words right there. Let's break it down. Acute means it doesn't have, it's not like a year-long thing, you know, it's not a very long-term thing. It's if you use too many NSAIDs over a couple of weeks, if you're not using them appropriately, if you're not staying under the, what is it, 800 mg a day or a dose that you're supposed to be taking, right? If you take 10 at a time, if some dumb patient does that, they're like, oh, I'm so hurt, you know, it's like, okay, your stomach is really going to be hurt then. Consumption of large amounts of oral iron might lead to gastric mucosal necrosis. Brown pigment might be seen over the damaged epithelium. We'll take some looks at the gross epithelium of the stomach. Oral sodium phosphate prep used for bowel prep for colonoscopies are associated with hemorrhagic gastropathy, so again, pharmaceutically induced. Cocaine-related injury. Remember we said that ischemia can cause a gastropathy. Alcohol is directly toxic to the gastric epithelium. And so ischemia is doing the same thing. Well, why do you get the gastropathy? Because the epithelial lining of the stomach gets ischemic. And so then your mucosal barrier breaks down. So that's how the dots connect there. Everything leads back in a gastropathy to the loss of the gastric mucosal layer. And your foveolar cells here up top, that's your epithelial lining of the stomach. All of these cells that are kind of clear, you know, up through here, I'll highlight some in yellow. Like those are the cells that produce mucin that lines the stomach. So if there's a necrosis of those cells or a cytotoxic injury to them, that's how you get your gastropathy. Acute gastropathy is most commonly seen in patients who are critically ill. And then at the bottom of page 4, going into page 5, we discuss normal in the stomach. It's a lot of your self-is principles. There's a homeostasis constantly between acid and base in your stomach, and you want to keep a set pH close to 1. So the secretions of the different cells of your stomach are going to be manipulated, so to say, in order to, they're going to be manipulated to maintain that target pH. And so there are many different secretions that your stomach and duodenum produce. And the heaviest is acid secretion by parietal cells. And parietal cells, again, are found in the body of the stomach, and that's the cell targeted by autoimmune gastritis. But then you also have enterochromaffin-like cells. Those are neuroendocrine cells that can release histamine. And histamine also stimulates gastrin production, or acid production, I should say. Gastrin is produced by G cells, which is another neuroendocrine cell, and that's, gastrin is directly responsible for conveying the message, for telling parietal cells, hey, we need more acid. And then you also have some chemicals that do the opposite. They inhibit gastric acid production, and examples of those are CCK, cholecystokinin, produced in the duodenum, and vasoactive intestinal peptide, VIP, and secretin, too, produced by S cells of the duodenum in response to the acidic contents of the stomach. I'd like to very briefly mention cholecystokinin here. Look, you don't have to remember one bit what this dude does, and I'll tell you why. Because the function of this peptide is in the name of it. Cholecystokinin, okay? Have you ever heard of a cholecystectomy? What's that? You get your gallbladder taken out. Okay, so the cholecyst part, we've seen that before. We know that means we're referring to the bile-producing gallbladder. Now, kinin, what does that mean? Well, kine, that root, that word root, is similar to kinetic energy, energy of motion, right? So cholecystokinin literally does, it stimulates kinesis of the gallbladder, and the gallbladder will squeeze itself and contract to spew bile out into the lumen of the duodenum. So that's exactly what cholecystokinin does, and it does this to neutralize the contents of stomach acid and also to promote the enzymatic digestion of fats. CCK squeezes the gallbladder. Bicarbonate ions are also very important. Again, we talk about neutralizing stomach acids. Well, bicarbonate is the ion that does it because bicarbonate is a base. So at a low pH, it'll sponge protons. Getting back more into the pathology of all of this, the disease-oriented process rather than the normal physiology. Prostaglandins have a cytoprotective effect on the gastric epithelium because they maintain the mucosa. And we've seen prostaglandin E2 before. That's a vasodilator, and that's responsible for keeping the ductus arteriosus open. And if we want to keep a ductus arteriosus patent or open for any purpose, we'll administer PGE2 to do so. So their cytoprotective effect stems from not only the ability to stimulate the production of mucus, but also the ability to stimulate bicarbonate secretion to neutralize acids. When the protective barrier is destroyed, acid is able to diffuse backwards to the epithelium and cause mucosal damage. Then we have a section discussing the mechanisms of acute mucosal damage. Most commonly, acid hypersecretion, and direct toxins are also pretty common too. We said alcohol is a toxin, NSAIDs are technically a toxin. Chemotherapy might irritate the lining of the stomach. Anything that reduces your bicarbonate secretion might lead into mucosal damage. And again, NSAIDs do that. Chemotherapeutics, there it is again, because it's important to know your gastric mucosa is constantly replaced. That's an actively dividing tissue. And it has to be because, well, again, we've said the stomach has a pH of 1. It's an inhospitable environment to cells down in there. So anything inhibiting cell division may really, really mess up the lining of your stomach. And then ischemic injury, as we've said, the best textbook example is cocaine because it causes really, really, really a whole lot of vasoconstriction. And I want you to remember that with all of these are gastropathies. And so histologically, you don't see any neutrophils there. And that's our differential for gastritis, gastropathy. Gastritis has neutrophils, lymphocytes. Gastropathy does not. Acute hemorrhagic erosive gastropathy. This is the one associated most often with NSAIDs, things like alcohol too. Chemotherapy can cause this. Again, hemorrhagic, you're bleeding everywhere. Erosive, the lining of the stomach is just flaking off and dying. And it's dying because of, well, acid is eroding it. Something's poisoning it, alcohol, or again, chemotherapy is stopping it from getting replaced. The symptoms should make a lot of sense to you. Epigastric pain, heartburn, nausea, vomiting, possibly hematemesis. Can range from occult blood to massive hemorrhage, and it might even, if it's chronic, the patient might be anemic, and so you would see like a low hematocrit and a low total red count in their blood. Now, grossly, hemorrhagic erosive gastritis looks like petechial hemorrhages on endoscopy. And the gross diagnosis or the scope diagnosis of these stomach lesions is what I believe to be the most time-consuming part of this SDL and the previous one to learn. Because, you know, like we're not familiar with what stomachs look like on the inside. So differentiating a hemorrhage from a bleeding ulcer is going to take some training of your eyes. So that's acute hemorrhagic gastropathy. And again, the acute nature, we're thinking a week or two tops for that timeline, but chronic chemical gastropathy. This is mostly referring to the histological changes that will occur when a gastropathy is allowed to continue for a very prolonged time. And this is also called reactive gastropathy. The causes of reactive gastropathy overlap a little bit with your acute hemorrhagic gastropathy, particularly with nonsteroidal anti-inflammatory drugs. But then there are a couple of etiologies, mechanisms unique to the pathogenesis of chronic chemical gastropathy that you don't see in acute hemorrhagic gastropathy. And those are bile reflux and, well, just bile reflux. So I had two things highlighted. I thought I was about to say two things, so I led into that. Bile reflux usually occurs in patients who have had a partial gastrectomy, particularly a Billroth 2. This is a Billroth 2 right here. You're going to separate the pylorus of the stomach from the duodenal bulb, and you're going to reattach the stomach to the, I think that's going to be the jejunum right there. And so you're basically going to bypass the duodenum. So what that means is that bile will get secreted from the gallbladder into the duodenum that's still there. And then bile is going to get to where the stomach is connected to the jejunum. And then it's going to have two choices. It can go continue down the bowel, or it can reflux up into the stomach. So that's your bile reflux. And it will lead to a reactive gastropathy that will look something like this. You're going to see corkscrew glands and foveolar hyperplasia. Foveolar, remember the foveolar cells of the stomach are those epithelial cells on top that are kind of puffy like marshmallows. So I realized I have some pictures in here of gastropathy as opposed to gastritis. So let's take this time to look at them now. What are we seeing here? Well, we know we're in the GI tract. There's a lot of glands, I would say. You think you're in the stomach because you don't see villi. And you probably get told this is a stomach biopsy on a test. So with that in mind, we would expect to be seeing glands just everywhere, but really what we're seeing is a whole lot of connective tissue. Like here is a zone in the lower left that just has nothing but collagen up inside it. And then here is another little patch right through here that just has nothing but collagen inside it. And then here is also another segment that is very, very empty and acellular in nature compared to, you know, the glandular zone in the middle here. So due to that, we're thinking, okay, there's some sort of reactive fibrosis, fibrous hyperplasia is the term going on here. But what do we not see? Is there anything that you think you would see in an inflammation that you're not seeing here? And that's neutrophils. You're really not seeing a lot of neutrophils or lymphocytes at all. Your immune response is very barren here. So that's what clues you in, oh, this is a gastropathy. And finally, there's some edema down at the bottom. And edema is kind of tough to learn how to see, but then once you figure out what it looks like histologically, it's hard to ignore. So normally, tissue is just pressed together. And in edema, there's fluid in between individual cells, and so they start to spread apart. And so that's the best way I know how to describe the edema I'm seeing right now, is that you can tell that the tissue at the bottom half of this slide is just more spread out than the tissue on the top half of this slide. And it's less dense because there was fluid edema filling into that space there in the lamina propria and pooling. And the pooling just gradually separated cells. They got looser and looser connections as the edema progressed. So this is typical of a drug-induced gastropathy, your NSAID-based gastropathy, even an alcoholic gastropathy. And this is something probably closer to the chronic side, I would say, than the acute, just because there is a lot of atrophy and scarring there. Here's more chronic gastropathy, your chronic chemical gastropathy, your reactive gastropathy. We're seeing foveolar hyperplasia here. And again, those foveolar cells were the epithelial cells on top. There's a wedge of them. And so the epithelial cells lining these gastric glands, hopefully by the time you take the test, you'll just immediately recognize those to be normal cuboidal epithelial cells. They're not parietal cells. They're not sheath cells. What else are we seeing? Vascular congestion with all the, well, here's a good example. All these red blood cells up here, you know, it's like those are capillaries that are just swollen. That's vascular congestion. And smooth muscle bundles that extend upward into the lamina propria. And I believe that, like, I can't really see any, so I'm not going to guess at it. So I said that you're going to want to be able to recognize a acute gastritis or gastropathy, any acute hemorrhagic bleed from a chronic ulcer. So here's what the bleed looks like. It's brown, rusty brown in color. On the right here, you're seeing some older bleeds in the top right there, and then this swath in the middle has some fresher bleeding to it. And they really are pretty small, and there's a lot of them. This is not really a situation with a erosive gastropathy or with an acute gastritis. You would not look at the stomach and just see one or two little petechial bleeds. No, you would probably see a territory of bleeding, I would venture to say. And that's going to differentiate it from your gastric ulcers, which we'll just take a quick look at here, which do tend to be more solitary lesions, and they might be clustered, but they're not. It's not going to be a family of ulcers or a tribe of ulcers, quite like petechial hemorrhaging would appear as. So recognize the Billroth 2 procedure as a source of bile reflux, and that bile reflux is damaging to the lining of the stomach, and that gives you your gastropathy, and you're not going to see any neutrophils or lymphocytes with it because it's cytotoxic. A key histologic feature in chronic chemical gastropathy is the paucity of inflammation, which is in sharp contrast to Helicobacter gastritis. And when we say inflammation, we're basically saying neutrophils and lymphocytes, right? And then here's with words what we just looked at. Chemical gastropathy is characterized by tortuosity of the gastric pits that gives these structures a corkscrew appearance. The lesion is secondary to excessive exfoliation of the injured surface epithelial cells, which gives rise to a prominent foveolar hyperplasia with elongation and tortuosity of the gastric pits. So let's look at that one more time, because you're not going to see those corkscrew lumens. You're not going to see those long, elongated stretches of foveolar hyperplasia in a gastritis, and you're not going to see them in an ulcerative disease, and you might see them in a particular type of polyp. But if you see these corkscrew glands, then gastropathy needs to be numero uno on your differential. Here it is again, corkscrew glands, foveolar hyperplasia, lots of epithelial cells. You don't see parietal cells here. You do see dilated capillaries. Look at that blood bleeding up there. Look at some down here, right? So that's where we're at. Another good picture, tortuous glands. Corkscrew appearance, again, they're not just straight down and out glands. It's not like a cylinder. I mean, it's got twists and turns to it. They're serpentine-like glands. And so that's why, well, you see the glands in kind of multiple planes here in this section. And again, the foveolar hyperplasia, very present, very present. You should start seeing mucous neck cells and parietal cells by the time that you're about yay deep in the epithelium, but you're not seeing it here. One more look, great example of foveolar hyperplasia. This is exactly what the text means when it refers to that. I mean, every single one of those cells in that box is a foveolar cell. Now that's bonkers. There's so many of them. And it's because they're stressed and they're damaged. So their responses just grow to try to cope. Almost it's their coping mechanism. Stress gastropathy. Solitary, sometimes multiple, mucosal defects, which can become complicated by upper GI bleeding. So the presentation of upper GI bleed, blood could come one of two ways, or you could see it endoscopically. But if you're diagnosing it based off of patient symptoms, then they're going to throw up some blood, or they're going to have occult blood in their stool. And the reason it's going to be occult blood, that means like invisible, hidden, not seen blood in the stool, rather than bright red hemorrhagic blood, is because it's an upper GI bleed, and because stomach acid denatures hemoglobin and plays with that iron that's in the middle of the heme ring, and it's going to oxidize that iron. And when iron gets oxidized, its absorption spectrum shifts, and so it'll pop off light at a ruddier color. It won't be bright red, it'll be darker brown. And that's, again, the same exact concept that's happening with methemoglobinemia. Is iron gets oxidized, and so patients with a methemoglobinemia have chocolate colored blood. And so that's why you don't see bright red stools with an upper GI bleed. Ulcers associated with burns and trauma are called curling ulcers. Ulcers occurring in the esophagus, stomach, or duodenum in persons with intracranial disease are called Cushing ulcers. I don't know anything about those right now. That's going to be something I look up further on a second pass. Remember that all gastropathies kind of go back to this breakdown of mucosal defense mechanisms. Any gastropathy, that's what's going on. You don't have a mucous membrane anymore, so cells get really, really damaged. So stress ulcers occur in critically ill patients, but they can occur in, I mean, there's not much of a rhyme or reason. I mean, this epidemiology section is 2 sentences long, so obviously there's a lot that we don't know about predispositions to stress ulcers. They usually occur in the fundus in the body of the stomach. Please remember, the fundus is like the dome on top of the body of the stomach. They sometimes develop in the distal stomach or in the duodenum or even in the esophagus. They tend to be shallow, but they can grow deeper if untreated. Acute ulcers are sharply demarcated round defects. The ulcer base is frequently stained black to brown by acid digestion of extravasated blood. In general, there is little inflammatory reaction noted histologically, and no fibrosis is evident. I didn't have a lot highlighted here, again, because in this SDL, they're trying to get you to associate stress gastropathy with people who are in the hospital for really bad things. So the question is going to incorporate, it has to incorporate this part of the text right here, kind of in the middle of page 7, that definition section talking about curling ulcers, Cushing ulcers. Patients who have an increased risk of stress ulcers have massive burn injuries or head injuries, and so that's what they want you to think. Here it is again, surgical or medical ICU. That's how they want you to make the diagnosis. Even though technically you're going to make the diagnosis based off of histology, they want you to be thinking trauma patient, critical care patient. So put that, like, sticky note that in your mind. For this SDL, there's one pathology that's associated with patients who are in a really bad condition, and that's stress gastropathy. Vascular gastropathy is pretty unique, and you're not going to have much trouble making this diagnosis, especially if they give you a picture for it, because all of these are malformations of blood vessels. And so we've gone through our cardio block already, and so we have a good understanding of what blood vessels ought to look like. So in these vascular gastropathies, you're going to get histology, if they give it to you, that shows you these dilated, tortuous, ectatic blood vessels. And remember, an ectasia is a malformation of a vessel. And that's what will characterize them on a slide. Now, grossly, they're going to be pretty easy to spot to the naked eye as well, because they're going to be very red. They're going to involve large areas typically. So let's start by looking at these pathologies. First, we have our gastral antral vascular ectasia, and this is also called watermelon stomach. And an ectasia is like a dilation of a vessel. And so antral ectasia is dilation of blood vessels in the antrum of the stomach. And specifically, I believe it's going to be dilation of mostly capillaries. And I've got an image right here that we can blow up and see a couple of really, really big, prominent blood vessels. Here's what I'm referring to when I say that. There's one right there. That's the lumen of a blood vessel. And here's another one right here. This sausage worm, earthworm looking thing. That's the lumen of a blood vessel. And it's just blown up, right? So that's your malformation. That's your vascular malformation. An ectasia, a dilation of blood vessels close to the surface in the antrum of the stomach. Now here's Dieulafoy's lesion. Same concept. Blood vessels that just look whack. What we see are histologically normal vessels with extremely large diameters. And so if you zoomed in, they'd have an epithelium, and then they'd have a media, and then their adventitia would be connecting them to the outside. And these can get pretty big. Individual ones can. Here's a cool, this is cool because you get to see it in two planes on this image on the right. Like here's when you're looking at the z-axis, what I've already circled, but then like here it is in like the XY plane. And then you can get this characteristic snakeskin-like appearance of the gastric lining on endoscopy if you have Dieulafoy's lesion. So snakeskin-like, it's the only thing that's going to give you a serpentine snakeskin-like appearance. And this table on the right I included just to remind you that anytime a patient comes in with an anemia due to a GI bleed, one of the very first things that you want to do is start them on supplemental iron to get their blood levels back to normal. So those are two of our three vascular gastropathies, again, in the text. Longitudinal columns of red tortuous vessels in watermelon stomach, so they're stripe-like. Histology reveals dilated mucosal capillaries, some of which may be thrombosed. So mucosal capillaries, they're the very small blood vessels very close to the surface epithelium. How do you think these patients present? Occult bleeding, hematemesis, yes, they're bleeding all over the place. They have a vascular gastropathy. Dieulafoy's lesion. Histologically normal vessel with a large diameter. Runs through the submucosa, can cause gastric bleeding, may be associated with NSAIDs. Finally, portal hypertensive gastropathy. Oh, I'm sorry. I think I must have messed up somehow, because portal hypertensive gastropathy is saying snakeskin-like appearance, so I must have labeled my slide wrong over here. Yeah, I sure did. That's okay, though, because now we know. And so this is not Dieulafoy's lesion. This is portal hypertensive gastropathy. And now hopefully you remember it extra well, because we have gone over it twice. So that's our portal hypertensive gastropathy with the snakeskin-like appearance. Only thing that's going to give you a snakeskin-like appearance. Dieulafoy's lesion is going to present grossly as just a bubble of blood, because that blood vessel is so big. So hypertensive gastropathy, seen in patients with portal hypertension. Where's your portal vein? It's underneath your liver, bringing blood from the gut to the liver. And so if blood backs up going into the liver, then blood's going to back up all the way into the mucosa of the GI. And so what we see in this portal hypertensive gastropathy is swelling and dilation of capillary beds within GI organs due to the elevated hydrostatic pressure downstream of the obstruction, so to speak, where you have portal hypertension. Now we talk about two hypertrophic gastropathies, and these are important to know because they're pretty unique. So you want to be able to recognize them like that so that you don't have to spend much time on these questions. That'll help you out for the tough ones, right? So first we have Menetrier disease. This is when your stomach just looks like a brain. And it's also called protein-losing hypertrophic gastropathy. So you waste protein, hypoalbuminemia, a lot of syllables there. Characterized by giant gastric rugal folds, often with antral sparing. So that's telling you what it is. You've got foveolar hyperplasia. And again, our foveolum, remember, is our epithelial lining of the stomach that makes mucus. And then concomitantly, you have oxyntic gland atrophy. And your oxyntic glands are basically those containing parietal and chief cells that you find in the body of the stomach. And so you've got reduced or absent parietal cells. So do you think your stomach is going to be more or less acidic? Less, probably. So you've got a higher pH. So your stomach's not going to like that. Probably an increased risk of infection, stomach infection, associated with this, I would assume. And we believe that Menetrier disease occurs due to local overproduction of transforming growth factor alpha. So that sounds a lot like TNF alpha, TGF alpha, so don't get those mixed up. TNF alpha is tumor necrosis factor alpha. And TGF alpha is transforming growth factor alpha. So you should think necrosis factor, growth factor. Well, a growth factor is going to make you grow, right? So that makes a lot of sense that too much of this growth factor is causing a specific type of cell to just multiply. So maybe I'm thinking your parietal cells and your chief cells, your oxyntic gland cells, are not responsive to TGF alpha quite like how your foveolar cells are. And indeed that's true, because TGF alpha binds to the epidermal growth factor receptor. When we think epidermis, we're thinking epithelium. So epithelial cells, yeah, foveolar cells, that's exactly what those are, right? But then Parietal cells, no, those are a little bit more specialized, you know. So the EGFR is on your epithelium. So that makes a lot of sense to me. TGF-alpha overexpression appears to direct gastric stem cells towards surface mucus cell differentiation, foveolar cell differentiation, at the expense of parietal and chief cell differentiation. So that's it. You have a limited currency of cells, and you can only spend them in one way. And if you just decide to take all of your stem cells and spend them on your epithelium, well, then you're going to have a really nice epithelium, but then like your glands are not going to be anything at all, right? And I do not have a photo of that in my PowerPoint because I thought that the cerebral like hypertrophy is just obvious. And again, if you know what's going on here, you get too much TGF-alpha, and so all your stem cells go to the epithelium. That's exactly what you see on histology. You don't have to remember very much about this. Last but not least, increased risk of gastric adenocarcinoma. Now we discuss Zollinger-Ellison syndrome. It's also a hyperplastic gastropathy, meaning your stomach is growing a little too much. Whereas in Menetrier disease, we saw that epithelial cells were the cells that were hyperplastic. In Zollinger-Ellison, your parietal cells are growing too much. They're stimulated. They get told, grow, 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 grow. And the messenger, the peptide that tells parietal cells to grow is gastrin. And gastrin is normally secreted by G cells at the antrum of the stomach in response to a meal. So if gastrin makes parietal cells grow, what would happen if you had a neuroendocrine tumor that constantly secreted gastrin? Well, your parietal cells would multiply all hours of the day, all around the clock. They'd just be popping out new parietal cells, and they'd probably be making acid too. So you'd see hyperacidity of the stomach. And if this went on for very long, you're going to see some heavy ulceration of the GI mucosa, particularly of the antral stomach and duodenum, because that's where stomach acid goes. It just goes downhill after it's secreted. It is important to note that this gastrinoma, this gastrin-secreting neoplasia, is usually in the duodenum or the pancreas, not in the stomach. So gastrin not only makes parietal cells work harder, but it also gets enterochromaffin-like cells producing histamine. And histamine mediates the same function, the same response as gastrin. It encourages acid secretion and growth of parietal cells. So ultimately, you get hypertrophy of the mucosa alongside ulceration, and the ulcerations are going to be more diagnostic of Zollinger-Ellison than any other gross or histological findings. Ulceration combined with hypertrophy specifically. So let's look at that now. Yeah, that's a lot of ulcers. Because, I mean, you're not just making a little bit too much stomach acid. I really mean you're making stomach acid all the time. Every time that this tumor makes enough gastrin to squeeze out, it goes to your stomach, and your stomach makes acid. So every time the tumor makes gastrin, your stomach makes acid. And so the result when that compiles is all of these ulcers. And these are duodenal ulcers. And if you got shown a stomach, would it be hypertrophied or atrophied? It would be hypertrophied. It would be a big old stomach in conjunction with these duodenal ulcers. That's Zollinger-Ellison syndrome. The patient has a tumor, probably in the pancreas. What's it making? Gastrin. What's that act on? Parietal cells. There you go. What's the big symptom? Chronic diarrhea. What's the diagnostic tool? Serum gastrin. Now we get to the money ball, peptic ulcer disease. So what's an ulcer? Let's think about it. Have you ever seen an ulcer? Ulcers look gross, just period. They don't really look bloody. They could be bleeding, you know, but they just look sick. That's the best way I can describe it. And they look like this because they've got a lot of neutrophilic exudate within their margins. So they're marginated. That's also an important thing of what makes an ulcer an ulcer. It's got a clearly circumscribed border to it. And it's often got a rim around it, kind of like a volcano or something, right? So over here on the right, notice these two ulcers that I've boxed out. We can zoom in and see that it's a trench, basically, again, a small little volcano or a divot, I may say, filled with this purulent, yellow-looking sickness. And again, all of that yellowness is neutrophils. It's your acute inflammatory response. And neutrophils, when they get on the scene, they help if they can by killing stuff. But if they can't help, they're just like, well, I can't do anything here. I guess I better just die. And they just blow up. And they spill their guts everywhere. And they're filled with proteolytic enzymes that will digest everything around them. And so that's why you see this sort of liquefactive necrosis in the center pit of an ulcer, is because it's got neutrophils. And what do neutrophils have? Proteolytic enzymes. So it just sloshes, acidifies, it turns to liquid, liquefies everything around it. That's an ulcer. So how do you get peptic ulcer disease? Well, typically, anything that makes your stomach too acidic, or anything that gets rid of the mucosal lining of your stomach, that's a big one, will give you a peptic ulcer disease. So understand, it's so important to understand, you got a stomach, you got tissue, and then on top of that tissue, you've got a mucosal barrier. And if that mucosal barrier goes away, you're getting damaged. And we just saw that with gastropathy. All gastropathies have that in common, that something happens to get rid of your mucosal barrier. And so if that continues long enough, if it gets chronic enough, then we're going to call it peptic ulcer disease when you start seeing ulcers all over the place. So this is kind of like a progression of gastritis or gastropathy. It's like an evolution of those two more basic pathologies. And this first sentence is really good. Peptic ulcer disease refers to a focal defect of GI mucosa that extends through the muscularis mucosa into the deeper layers of the wall. So understand, it's got to be a deep-seated lesion to be considered an ulcer. And for it to get that deep, for it to penetrate your gut wall that deep, it has to have been there for a pretty long time. So this is not just a instantaneous development, this ulcer. And when we're saying it extends through the muscularis mucosa, let's refresh our memory on the different layers of the GI wall. And the muscularis mucosa is right here. I'll highlight that box in green that's pointing to it. And this layer is a layer of smooth muscle, but it's not your circular or longitudinal layer. No, it's inside that. And it functions very similarly to the tunica media in your medium and large arteries. It can just reactively, reflexively contract and dilate whenever it needs to, depending on local stimuli. So that's what your muscularis mucosa does. And an ulceration is going to be classified as anything that just gets down into the muscularis mucosa from the lumen. So it's going, the damage is coursing from the lumen down through the muscularis mucosa. Now that's a lot of damage, because what we've seen, well, yeah, you might have some neutrophilic response, you might have some lymphocytes, but at least you still have an epithelium. And in an ulcer, as we'll look, you don't have an epithelium. You're getting rid of your lamina propria. You've just got this submucosal layer is what you're left with a bunch of granulation tissue and capillaries and neutrophils running throughout. Let's talk about how you get ulcers real quick. Essentially, I can narrow it down to anything that's going to decrease the amount of prostaglandin E that you're making. Anything that's going to compromise that mucosal barrier might lead to ulcers eventually. And the two most common means that happens by are through Helicobacter infection, which is going to be directly injurious to the epithelial cells that make prostaglandin E, those foveolar cells. And then the second route is through NSAIDs, which are going to completely block the synthesis of prostaglandin E, leading to the dissolution of that mucosal barrier and the eventual erosive damage of the stomach lining. So just these aren't mutually exclusive. You could have both at the same time, and you need to be aware of both, and you need to be doing a workup for Helicobacter, even if patients like, oh yeah, I take 16 Advil a day, you still need to do your Helicobacter workup. And even if you've confirmed Helicobacter and the patient doesn't take any over-the-counters, you need to say, hey, please avoid NSAIDs, use antacids, use a proton pump inhibitor instead to manage your gastrointestinal symptoms. So they're synergistic, that's the word for whenever two things have a multiplying effect with each other. So your stomach gets hyperacidic, and the acid just melts the wall of your GI tract. And specifically in Helicobacter infection, it's been a while since we talked about that. I want to remind you that in Helicobacter, first the pH of your stomach goes up because Helicobacter has urease, but then your stomach wants to compensate for that and maintain homeostasis, so it ramps up parietal cell acid secretion. So then you get a compensatory hyperacidity of the stomach, and that can contribute to the development of ulcers in the setting of a Helicobacter infection. Pathogenesis, about the same thing we were just saying. The mechanism of duodenal ulcers is gastric hyperacidity. So there's duodenal ulcers and gastric ulcers, and this section is breaking it down into how do duodenal ulcers form, how do gastric ulcers form. So duodenal ulcers, well, whenever your stomach is done churning up its contents, the pyloric sphincter opens and it passes the contents of your stomach into the duodenum. And so normally in the duodenum, you have a lot of bicarbonate secretion occurring, and that bicarbonate is there to neutralize the very low pH of the entering stomach acids. So if anything's happening to lower the acidity of your stomach, well, then what you would observe in the duodenum would be an increased bicarb secretion to try to buffer that hyperacidity. Getting straight back into the text. The duodenal, where do I want to go from here? Normally your stomach spits what it has into the duodenum, and then not only does the duodenum secrete bicarb, but it also tells the stomach, hey, close that pyloric sphincter. So that's an important part of it too. And in a patient with a duodenal ulcer, this signaling process is impeded due to the hyperacidity of the region. So this just creates a big downward spiral of symptoms that can get worse and worse and worse and compound as they progress. That's, I believe, what I wanted to say. Remember, you're seeing an increased pepsinogen 1 in Helicobacter gastritis, hyperpepsinogenemia. And remember also, you're going to see a decreased pepsinogen 2 in autoimmune gastritis. So gastric ulcers are different from duodenal ulcers. The mechanism of gastric ulcers seems to be compromised mucosal defense due to Helicobacter or NSAIDs, or again, chronic alcohol use, ischemic death of the lining of the stomach. And then at the bottom, bile reflux and pancreatic secretions have been suggested as causes of gastric ulcers. So maybe you get bile reflux if, as we were saying in the previous section, your pyloric sphincter doesn't close due to the hyperacidity of the duodenal lumen. Or maybe you get bile reflux if you've had that Bill Roth 2 gastrectomy, as we just looked at a few minutes earlier, right here, right? Maybe that gives you a bile reflux. And so that can stem into gastric ulcer disease, peptic ulcer disease. So there's a lot of roads to approach peptic ulcers from, okay? I want you to take that away and be able to think your way through, how did this ulcer get here? And this is not a memorize me SDL, and neither was the last one. No, none of these diseases of the stomach are memorize me, because they all present exactly the same, you know? And it's like, yeah, you can separate some of them based on histology, but that's not what a question will be asking you. So then we talk about where these ulcers are. Duodenal ulcers are more common than gastric ulcers, and they tend to be right next to the pylorus of the bulb, again, of the duodenum. Then gastric peptic ulcers typically occur at the interface of the body and antrum, so towards the end, towards the lower end of the stomach, and then along the lesser curvature. So it's going to be on the superior aspect rather than the inferior aspect, because the inferior has the greater curvature on it, and the superior aspect of the stomach has the lesser curvature. It's shorter in distance. And this is bringing it back home to where we started. An ulcer is filled with purulent exudate. That's so important, because that's why it looks shiny and glistening. And that's why if you cut open an ulcer, what do you see here? What do you see up top in this ulcer, yo? You just see nothing but neutrophils. And it's like, that's the reason for your exudate right there. Microscopically, refer back to this, and I'd say maybe look up some pictures of ulcers if you really want to, because ulcers can appear all throughout the GI tract and in other organ systems too. It's not a stomach thing particularly. So knowing an ulcer, knowing all about an ulcer is very useful, because again, you can get tested on it from a lot of different angles. But microscopically, what do you see? A lot of neutrophils on the outside, and then underneath the neutrophils, lots of collagenous connective tissue, granulation tissue. That's new capillaries growing in response to basically cell death. Scarring may involve the entire thickness of the wall and pucker the surrounding mucosa into folds. What does that look like? Let's take a look. Here's a histological section of a gross ulcer. This is so cool, yo. Here is the ulcer in the middle. It's like cup shaped or U shaped right there. And notice that we've got, I'll show you in green, just totally normal epithelium to the left and to the right of this ulcer. But then again, right there in the middle, I mean, there's nothing there. And remember that we said that this is a injury that extends very deeply into the wall of the gut, even down to and through the muscularis mucosa. So going back one last time to this overview slide, again, we said that an ulcer can go down that deep into the wall. And if we go back to the tissue section, it's like, yes, that confirms. Look how deep that ulcer has grown or invested down into that wall. It's melted it all away. So that's an ulcer on histology. And if you zoomed in, if you got a section of ulcer on a test question, they would be zooming directly in on the ulcer itself. And it would just be, I mean, you see really clustered cellularity up towards the top, and that's your neutrophils. And then as you go down, you just see collagen, fibroblasts, and granulation tissue. Here's what duodenal ulcers look like. I put a normal duodenum in the lower left here, and then in the middle of this slide is basically some precursor lesions to ulcers, just kind of some point inflammation there. I think you would be able to consider that like, I mean, if that were in the stomach, you'd call it a acute gastritis, hemorrhagic gastritis, or gastropathy. But then on the right side here are your duodenal ulcers, and man, it's massive. It's that ugly pustular yellow color again because there's neutrophils in there. And look at this sucker in the lower left, the bottom image. I mean, it's glistening, it's glimmering, gleaming, it's so soapy almost. And why is it just so liquidy? It's because it's a liquefactive type of necrosis with neutrophils just melting everything. So that's your ulcers. What I would like to do now is help you understand, this is a differential you might get asked to make on a test, the difference between an acute hemorrhagic or erosive gastritis or gastropathy versus peptic ulcer disease, because they could show you one of these and have A, peptic ulcer disease, B, acute erosive gastritis in the same test question. And again, symptomatically look really similar. With words even, it might seem really similar to you. And so an ulcer is always going to have that very distinctly well-marginated, well-circumscribed, glistening sort of exudate to it versus a hemorrhagic gastritis, which is going to be a dark, dark, dark color. It's going to look like clotted blood, and there's usually many of them in a local area. There's usually a few of them clustered together versus ulcers, which do like to be, they start solitary and they just expand in size as they grow. Here's another look. Here are some stress ulcers. Remember, we said a stress gastropathy associated with hospitalizations. And a stress ulcer could be associated with chronic stress, lifestyles, jobs, things like that. Here's another gross view. This is an antral peptic ulcer. So it's in the antrum of the stomach, so down towards the bottom. Again, it's got a discrete border, and it's got that white, yellow, tan pustular color to it. Versus a hemorrhagic gastritis, this stomach on the left here is kind of orange red, you know, like it's been irritated, and you can see that there's some mucosal bleeding going on inside of it. Here's a real bloody ulcer. I wanted to include this just to show you that yes, ulcers might bleed sometimes, but again, this is a solitary lesion and it's still very glistening. It's wet down in there, and so that's the exudate that's making it that wet. And then here's a very widespread example of an acute erosive gastritis with so much bleeding that the stomach just appears red. And then you can just kind of, I'm not going to highlight anything because it's very diffuse, but then there's some darker patches down in there. And the last slide I got, looking at these histologically, here's an ulcer. You can tell that this is an ulcer right here. It's, again, that cup U shape in the middle of otherwise normal epithelium. And you're going to have some fibrinoid necrosis and kind of necrotic debris on top of it, kind of like a scab on top of a scrape. That's what you might see on top of an ulcer. Versus an acute hemorrhagic gastritis, lots of neutrophil involvement. But what's really important to note is that the glandular structure of this tissue has been preserved. So you're not going to see glands on histology with peptic ulcer disease if you're zoomed in on where the ulcer is. Let's wrap up by discussing the presentation of an ulcer. Epigastric pain, very common. Patient doesn't want to eat. Maybe they'll report that they've just got kind of an intolerance to food in general, and they'll have an anorexia. But I know that's usually associated with cancer, but trust me, if you have really bad GI symptoms, I mean, you're going to see like a kind of a induced anorexia because eating is going to become painful for some of these patients. Bleeding, anytime you observe bleeding out of the mouth or the anus, you should have a lot of GI things on your differential, and then you should work to figure out where that blood's coming from. Vomiting suggests obstruction. I don't particularly understand the obstructive component to it, but I imagine it really hurts whenever food slides across some of these ulcers. And perforation too, we saw that the ulcer just dives down into the GI wall, and if it chews all the way through the GI wall, that's a perforation. So that's what can happen if these things aren't controlled. And how are you going to treat these things? Well, your initial management is you want your patient to stop aspirins, NSAIDs, naloxone, anything like that, because that's going to, all of those drugs block cyclooxygenase and prevent your gastric mucosa from forming. So you need to explain this to your patient in a succinct, easy to understand way. And you need to tell them that to manage their pain, you'd like them to use things like Tums or a proton pump inhibitor. I suppose that you could keep a patient on aspirin if they were, you know, if it's like a baby aspirin, like a cardiac patient. But other than that, yeah, you're gonna have to give them the sales pitch on stay away from the Advil. Lab findings, nah, not for peptic ulcer disease. Diagnosis, anytime you diagnose any organ, you want to take multiple biopsies, especially in the GI tract. And complications, we've discussed them a little bit. Hemorrhage, melena is your upper GI bleed, and hematochezia is your lower GI bleed. And the difference in coloration is because of stomach acids oxidizing the iron and heme. You might observe iron deficiency anemia on a blood count or something like that, or a low hematocrit. Perforations can lead to a peritonitis, which is going to be an infection of the peritoneal space. You might see a pneumoperitoneum. We'll learn more about that in clinical medicine, I'm sure. And that's an emergent sort of situation. Penetration is whenever an ulcer dives into a neighboring organ. Now, this can compromise the function of the neighboring organ. And what's right next to the stomach? Well, the pancreas is next to it. The liver's kind of next to it. The colon is certainly next to it, the large intestine. So that would be a very bad complication. And obstruction, associated usually with duodenal or pyloric ulcers, because those are very narrow spaces. That is correct. And oh, that makes a lot of sense. So the obstruction component could come from muscular hypertrophy following a lot of damage. That makes sense. Or scar tissue contraction. That also makes a lot of sense, because granulation tissue gets laid down, but then that fibrous component, if it wins out, then you know you've basically just got like, it's a scar, it's a scar. And so if you have a scar in your pylorus, well, then that constricts the lumen of that narrow area. And so it can be harder to pass food through there. Okay, I'm glad that we put one and one together on that. And finally, ulcers very rarely transform into malignant cancers. So that's it for this SDL. Again, the best way to explain it is this is not a memorize everything SDL. In fact, there's very little to memorize. Recognize the hypertrophic gastropathies, because again, those are so unique. It's easy to ask a question about those. Other than that, just do practice questions on your own and get a feeling for what they could throw at you for this multifactorial organ called the stomach. Thank you very much.